Good morning, everyone. Thank you for joining here, inside and outside, and thanks for allowing us to be part of the medicine meeting still, or forcing us perhaps. But it's nice to be. We're having a sequel to our last mini series on stroke. So today we have episode 2, and it's about anticoagulation after stroke. What does it say? Who, when, what? It's a topic that is in flux constantly. So Dr. Sandane Chauke is our senior registrar. He's recently now basically reviewed the literature that changes quite rapidly, and there's always new studies coming out. But she's going to bring us up to date on that, and it's probably relevant to most of us sitting here and online. So thanks, Sandane, for doing that and bringing us up to date with anticoagulation post-stroke.
All right, good morning, everyone. I'm Sandane, as mentioned, and today I'll be talking about anticoagulation post-stroke. Okay, so the main things that I'd like to cover, because it's quite a dense topic, I'd like to cover who are the people or the patients who are indicated to get anticoagulation after stroke, what is the best medication that we should give, or the anticoagulation type, as well as when is the optimal time to start anticoagulation after stroke. So just giving a backstory, I mean, when it comes to stroke, we talk about whether it's an infarction or a hemorrhage. So you can get cerebral infarction, whether it is a cardioembolic thing that happens or atherosclerotic event that happens, or intracerebral hemorrhage or subarachnoid hemorrhage. So then when it comes to the etiology, these are also important as to directing us what mode of secondary prevention we'll be using. So the choice classification in 1993, was looking at essentially the causes of stroke, whether it's 1, a large artery, atherosclerosis, 2, is it a small vessel occlusion, or is it cardioembolic, which is the main reason why we are here today to talk about that, as well as other determined causes such as cervical artery dissection. And there used to be a term called cryptogenic stroke. So that encompassed 3 main things. The first being patients who are not necessarily fully worked up. So maybe they pass away before the time for us to get, an optimal workup for them. Or is it patients who have maybe 2 or more possible causes? So somebody maybe who has atrial fibrillation, and then they might also have atherosclerosis large vessel. So you're not necessarily certain what caused it. And then there was a third group. So the third group is now termed ESUS, and we'll come to that. That is a group of usually young patients who are fully worked up, and then you can't necessarily find a cause. So we'll talk about that now. So our role essentially will come here, the etiology, figuring out what is it that caused the stroke, as well as the secondary prevention. So the last talk that we spoke about, as Prof. Mochan mentioned, was with regards to antiplatelet therapy after strokes, but today we'll be talking about anticoagulation. So coming to who. So there is this slide, and towards the end, there'll be another slide. So I encourage us to ask questions and to interact when these slides come up, the who, what, and where. All right, so according to Tinon et al. And his colleagues, they established a list of what are the indications for anticoagulation. So firstly, we know about antiphospholipid syndrome, and where there's question marks, that's where we now start to review what literature says. So cervical artery dissection was on this list, but as we'll come to know, it might not be an indication for anticoagulation. Atrial fibrillation, as we know, as well as left atrial or ventricular thrombus, and then also things like mechanical left ventricular assist device, left ventricular ejection fraction of less than 35. I put a star there so that we can discuss about that as well as valvular heart disease, and then the question mark in front of ESUS. So why do...
Tell them what ESUS stands for.
So ESAS essentially stands for embolic stroke with undetermined source, right? So we'll cover that just now. Okay, so why do we give anticoagulation? So essentially, the movement had gone to looking at the actual thrombus, right? So Mayo Clinic describes a thrombus as a gel-like substance that is made up of, comprised of fibrin, platelets, red blood cells, von Willebrand factor as well. So when coming to, sorry about that, the thrombogenesis. So that picture on the right looks at thrombogenesis that happens in the arterial system as well as in the venous system. So then when looking at the arterial system, you see how the atherosclerosis happens in the coronary arteries, or even in the carotid arteries. And then this essentially can lead to a stroke or an ischemic heart disease. So the pathogenesis there would be quite chronic. You have recurrent endothelial injury that then recruits platelets to come to play. And then the platelets predominate in the arterial system. As in the venous system, it's a low pressure system. And this is hypothesized to also happen in the heart in cases where patients have maybe atrial fibrillation or dyskinesia in the heart, low pressure system in the venous or in the cardiac, and then the clot then becomes rich of fibrin and then trapped erythrocytes. So taking it back, not back, towards NTS and his colleagues, they then postulated that you have to consider red thrombi versus white thrombi, depending on the thrombogenesis pathway. So the red thrombi, as mentioned, would be in a low pressure system, and it would likely respond better to anticoagulation as opposed to the white thrombi, which basically will be predominant from the local platelet activation and aggregation to the formation of the white thrombus, and therefore antiplatelets would be the best to consider. So this is basically summarizing what I just said, but there was a Mr. Clean Registry Biobank that looked at the composition of a thrombi. So they basically did thrombectomies on these patients, and then they assessed what type of clot you'll get. And the reason why we considered, or they used to consider, embolic stroke of undetermined source as as patients who would benefit from anticoagulation is because this were the findings from the Mr. Clean Registry. So as you can look, on the x-axis, it looks at non-cardioembolic, cardioembolic, and undetermined. So remember, undetermined used to fall, was cryptogenic, right? And then one of the things was embolic stroke of undetermined source. And you can see how there's similarity. So essentially the red box here in this bar whisker plot basically looks at the erythrocyte component. And then higher up, you see the fibrin and platelets. And you can see how, I don't know if I have a pointer here, but between the cardioembolic and undetermined, they look quite similar. And that's how they then hypothesized that maybe the embolic stroke of undetermined source would have a similar thrombus composition, and thus they would benefit from anticoagulation. Okay, so in continuing as to who are the patients who get anticoagulation, one of the diagnoses would be cervical artery dissection. In fact, when I started, what we used to do when a patient had cervical, or at least you are hypothesizing that this person's got cervical artery dissection, you wanted to move fast to confirm this diagnosis so you can start anticoagulation. However, studies suggest otherwise. So when you have an intramural, when you have cervical artery dissection, you can have an intramural hematoma that can cause stenosis or vessel occlusion. You can then get a consequence of cerebral infarction, whether it is from the hemodynamic mechanism of occluding or an artery-artery embolization. So then there was a CADIS group. It was a randomized controlled trial that looked at 250 patients with this extracranial carotid and vertebral artery dissection. They compared the use of anticoagulation and antiplatelets in these patients. And what they found is that there is no significant difference between the treatment arms. Also, there's a low recurrence of stroke up to 1 year. So then the American Heart Association guidelines changed in that antiplatelets are not considered to be inferior. So you can use antiplatelets in these patients. So this is the reference of the study I'm talking about. And in addition, in 2021, we had the TREAT-CAD study, which basically showed the same thing. So there was now 2 randomized controlled trials that show that antiplatelets are really not inferior. Okay, we talk about the ESAs that I've been referring to. So this term was coined in 2014. It basically refers to large vessel strokes. So it's embolic, so it's not lacuna strokes, not the small ones. And 70% of all ischemic strokes that typically happen in young essentially become ESAs after we've worked them up extensively. So the rate of recurrence of a stroke is 4 to 5% a year. And these are a list of the hypothesized cause. So you have an ESAs, you work them up, you can't figure it out. What is the cause? This is the hypothesis list that they have now established. So could it be an atrial cardiopathy, left ventricular disease, covert atrial fibrillation, patent foramen ovale, valvular heart disease, atherosclerotic plaques, or cancer, since it causes a hypercoagulable state? So this is a lovely illustration that is taken from Dios et al. Not only does it show these 7 hypothesized causes, but it's got color grading at the back. So this color grading at the back, we see red that goes down to white. And remember, we spoke about red thrombi and white thrombi. So in the red background, these patients are more likely to have a red thrombi as opposed to going to the white side. They're more likely to have a white thrombi. So now there were many proposed mechanisms of ESAs being embolic. As you have seen in the previous image, most of them are cardiac pathologies proposed. And then there was now studies comparing the likely response to anticoagulation in these patients. So you then had the Navigate that looked at rivaroxaban, and as well as the RESPECT trial that was then conducted to assess if there's a benefit of anticoagulation over aspirin in these patients. And it was found that there is no benefit to anticoagulate over to giving aspirin in a patient with ESAs, provided you didn't find, whether they have atrial fibrillation or not. So then the RESPECT trial, no significant difference between the effect of dabigatran and that of aspirin on the risk of recurrent stroke among the ESAs patients. The incidence of major bleeding was not more for the dabigatran group, and clinically more relevant non-major bleeding events in the dabigatran group. So that's also a reference to the study. And then what about atrial fibrillation? So atrial fibrillation also hypothesized, but in these cases, if you are quite suspicious of atrial fibrillation, then we have to prove it before we can give anticoagulation. So initially, it was considered that most important underlying mechanism of ESAs. However, randomized controlled trials on prolonged cardiac monitoring. So outside of doing an ECG and a 24-hour Holter, they then had these studies that were looking at cardiac monitoring for a longer period of time. So you had the Crystal AF, the Embrace, the Find AF, and it found that with the Embrace had higher rate of atrial fibrillation detection than Crystal AF, and that AF may be detected in 30% of ESAs during long-term follow-up. So it does show that long-term cardiac monitoring in your ESAs patients, you might pick up atrial fibrillation in these patients. And then what about atherosclerotic plaques? So with atherosclerotic plaques in the aortic arch, cerebral or intracranial arteries, remember they fall onto the white colored end of the spectrum. So they're more likely to do well on giving them antiplatelet therapy. In fact, there needs to be more randomized controlled trial, but essentially Navigate ESAs, the carotid plaque found on the ipsilateral to the ischemic stroke instead of on the collateral side. So here, we don't really have much randomized controlled trials if we were to use anticoagulation here, so we'd still stick to using antiplatelets. And then when it comes to atrial cardiopathy, so this is essentially, there's an absence of a thrombus in this case, there's just atrial cardiopathy. So thrombi may form in diseased left atrium, even in the absence of AF. So in the event that there's a thrombus, then it would be beneficial to give anticoagulation. However, there's no strong evidence to start anticoagulation as yet. And then what about patent foramen ovale? So the question here, when it comes to patent foramen ovale, is this a direct cause? Is it a risk factor, or is it an incidental finding, right? Because we are basically trying to see the potential mechanisms that can happen when somebody has a PFO. So you can have a paradoxical embolism that develops, maybe somebody's got a DVT and then it migrates up, paradoxical embolism, or in situ clot that forms, or even an arrhythmia that can form in these patients. And a powerful marker is that usually if you find a non-incidental PFO at a young age, that's when you would consider doing something about it. So as mentioned, the consideration, the age of the patient, the morphology of the PFO, yeah. So in ESA, what they found also, in addition to the patent foramen ovale in ESAs over 60 years, it showed that they had a lower risk of having recurrence of a stroke. However, there were other trials that suggested that, especially in younger patients, in the event that you find a PFO, it would be beneficial to maybe close it, as well as give them antiplatelet therapy. So these recent trials, percutaneous device closure reduces the risk of further stroke recurrence with an acceptable complication rate. So then from 2017, the Mass et al. Looked at the patent foramen ovale closure, giving anticoagulation versus antiplatelet after the stroke, after closing the patent foramen ovale, as well as in 2017, they also looked something similar, and in 2018 as well. But then it shows that PFO closure plus antiplatelet therapy can lower risk of stroke recurrence. So, yeah. And then what about cancer? So with cancer in ESAs, there's an increased stroke risk. It varies by the cancer stage, as also by the type. You find that in your lung cancer patients, it's more likely to have higher risk stroke. There's several pathologies, whether it's a hypercoagulable state, whether the tumor embolizes, mechanical compression of vessels, and so on. And then here, with the randomized controlled trials that were done, it is unclear if there is a role for anticoagulation in these patients. Okay, and also as to mention, when it comes to hemorrhagic stroke, we mainly focus on anticoagulation, intracranial hemorrhages. It's already, I mean, if the patient already had an indication, so let's say this person has got atrial fibrillation and they were on anticoagulation, and then they now develop an intracranial hemorrhage, NOACs associated. And then, so essentially here, I should have put it later actually, talks about how NOACs, so novel oral anticoagulation agents, are better, right? They have a decreased chance of bleeding risk compared to warfarin. So reinitiating oral anticoagulation compared to no treatment significantly reduces the risk of an ischemic stroke. Okay, so this is the slide I was talking about that encourages us to talk about this indications. So these are the proposed answers based on what I've just talked about. That one, conditions with potential high risk of cardiogenic reembolization is, these are the patients who will have you start anticoagulation. Second is ESAs. So just having an embolic stroke of undetermined source doesn't mean you have to start anticoagulation. And then atrial fibrillation, you have to start antiphospholipid and dissection. So my question to you, and also to maybe the cardiology team, is a ejection fraction of less than 35 an indication to start anticoagulation in a person who's had a stroke alone?
From cardiology is here.
I think you see it from the stand, of course, to anticoagulate. In patients who have very poor ejection fraction, under 30%, where you do see spontaneous vaginal contrast, and you do have some phenotypes that are associated with increased homogeneity, such as non-contact, then you might consider it. However, it is not a strong. But currently,
Okay, thank you. Yes.
So the measure are under the stack.
Thank you. Thank you.
Can you just repeat that what Prof. and Dr. Patel said for the guys online?
Okay. So according to the cardiology department, there is no indication essentially if a patient just has an ejection fraction that is less than 35. And at this point, unless if there is a thrombus, basically that's the gist of it. There's been a trial that also showed this. Okay.
Just to ask that, so that we mentioned that spontaneous contrast, I mean, what's it called, hemorrhagic smoke that you see on the echo, so you don't consider that anymore as an indication then by calculators and right?
not on its own.
All right.
I think if the LV function is very poor and there's no other source, there's recurrent embolization, then you might say there's a class 2 indication potentially for it, but there isn't strong evidence.
All right. So now going on to the what. So what basically, we're looking at what agents would you use as anticoagulation. So we're taking it back to the international stroke trial. And this stroke trial, not necessarily that we're using it to help guide decisions now, but it gave us insight onto the things that we're doing today. So this trial looked at nearly 20,000 stroke patients who were randomized within 14 days of stroke onset. And there were treatment arms where there was no antithrombotic therapy given. There was parenteral heparin, and then there was aspirin that was given. And basically this graph on the left looks at, on the x-axis, you're looking at the treatment groups, so the heparin and the aspirin that was given, and then on the y-axis, we're looking at the outcomes. And when you look at the heparin arm, you find that it did reduce the risk of a recurrent ischemic stroke, but there was major hemorrhage that happened more likely in these patients as opposed to in the aspirin group. So we found that, parenteral anticoagulation reduces the risk of stroke. However, the risk-benefit ratio between having a recurrent stroke or having a bleed, you found that they were more likely to bleed. And there was no overall benefit of starting anticoagulation early, which we'll talk about when we get to the when. But the main gist of this is how it helped us direct that the treatment option to consider was that IV heparin given early was considered dangerous or had adverse effects. In fact, there was also a RAF study, but the main purpose of this is to determine the timing to give anticoagulation. So the reason I'm mentioning it here under what is that there were different treatment groups. They had about 1,029 patients. 766 were given anticoagulation, 263 no anticoagulation. And there were then treatment arms where they gave low molecular weight heparin alone, or they gave warfarin or DOAC, or lower molecular weight heparin followed by warfarin. And the findings here under the what is that DOAC was noted to reduce risk of bleeding as opposed to giving low molecular weight heparin alone or followed by an oral anticoagulation. So basically looking at that, we found that DOACs had a reduced risk of bleeding as opposed to lower molecular weight heparin, and then that's not supported. So then between warfarin and the direct oral anticoagulant, warfarin is still considered safe and effective. Major bleeding risk of 1.3 per year, and then just 37% relative risk reduction of stroke compared to just giving antiplatelets. And then basically looking at the anticoagulants in this case, basically that the DOACs are effective in stroke prevention and have half the risk of intracranial hemorrhage as opposed to warfarin. So in fact, so basically this is quite repetitive, but it's repeating what I just said now. But outside of that, there were also phase 3 randomized controlled trials that were looking and comparing whether to use warfarin or to use the NOACs. So novel direct anticoagulants were introduced in clinical practice in 2008. And they either, you can reduce the coagulation through direct inhibition of factor 10A or 2A, and it decreases thrombin formation and fibrinogen conversion to fibrin. The NOACs were then noted not to be inferior to warfarin. As mentioned, these trials, the Relay, Rocket AF, Aristotle, Engage AF. In fact, there was a meta-analysis looking at this, and this is basically a table. And the purpose of this, not necessarily to look, I know it's quite a busy slide, but to look at all these trials that were done, comparing dabigatran and warfarin under Relay, Rocket, looking at rivaroxaban and warfarin, Aristotle, apixaban and warfarin, and showing that these oral anticoagulations are not inferior options to warfarin, and that warfarin can be actually NOACs can be a great anticoagulant that we should consider in patients who have had stroke. And this forest plot is basically looking at this meta-analysis, comparing the efficacy and safety of these new oral anticoagulants with warfarin in patients with atrial fibrillation. In fact, what to note is that a lot of these studies were done in patients with atrial fibrillation. And then you see that the data that's falling on the right of the midline favors the use of warfarin, and that on the left favors the use of NOACs. And what you can see there is under the efficacy that these NOACs are able to reduce the recurrence of having an ischemic stroke. But also under the safety, they have a lower risk of intracranial hemorrhage. And that's why we like them per se, because they have a less profile for adverse events. So then under the what, for non-ventricular atrial fibrillation, you find that DOACs are better than warfarin. And in our case, we then use oral anticoagulants as first-line therapy in these patients. Prof, do you have any addition here? Okay. All right, and then we're at the last section of the talk. We're talking about timing. So timing is also something critical to establish, because you don't want to start too early and then offer the risk of bleeding or hemorrhagic transformation, or start too late and risk the chance of somebody having another stroke. So those are the issues that we want to determine, or that are essentially at play here, is determining or rather trying to that balance between early anticoagulation and later. So there has been a lot of trials here, and as you can see, there's been a timeline going back from 1997, as mentioned in the international stroke trial, remember, where they looked at IV heparin and aspirin, coming back to currently when there are ongoing trials. So we'll just go through some of them. So the international stroke trial, as mentioned, this has led to the common practice of delaying initiation of anticoagulation after stroke for the first 2 weeks. So that was the initial decision. Wait, don't start anticoagulation after a person just had a stroke. If it's indicated, wait for at least 2 weeks. But this was in 97. And then we moved on to 2013, where we had the European Heart Rhythm Association that then proposed a new rule of how to look at it. They spoke about the 1, 3, 12 days rule. So this essentially says that in a case that a patient has maybe a transient ischemic attack, you can start anticoagulation after 1 day, that's the 1. If the patient has a mild stroke, then you can start after 3 days. If it's moderate, you start after 6 days. And if it's a severe stroke, you start after 12 days. And here, the evidence that large infarcts are more likely to undergo hemorrhagic transformation than small infarcts came to play, because if it's larger, you're likely to wait longer, right? And then we then had the American Heart Association in 2018, revised also in 2019. It was considered reasonable to anticoagulate within 4 to 14 days. But in this case, I mean, 4 to 14 is also a broad window. Do I start at 4 or do I start at 14? But then we had to now consider the factors that influence you starting at 4 or at 14. So this is basically a summary of studies on early initiation of anticoagulant therapy in patients with recent atrial fibrillation. So this here you have this table that basically summarizes these studies. So from the top, these are observational studies. So they were not randomized control trials. They were just prospective observational studies that influenced that 4 to 14 day start. And this basically in that graph shows that they were following these patients up for 90 days. However, what one must note about these trials is that they only worked on mild strokes. So people with an NIHSS of about 3 to 8, and then they started anticoagulation from day 4 to 5. So they don't necessarily do it on large strokes per se in these trials. So it was the NOAC ISP, the SAMURAI NVAF, and the RAF. And here, this was basically a summary of the findings that they found. So this included patients with recent ischemic strokes, as mentioned. And then it found that early DOAC treatment, right? So looking here at the first, so looking at the x-axis, the first study that was done in 2016, the NOAC ISP, was looking at the risk of having recurrent ischemic stroke. It was still there. However, intracranial hemorrhage was lower, was on the lower end, but also considering that they were looking at patients with mild strokes. So they found that starting anticoagulation earlier was now an option because they had less risk of bleeding. However, you'll ask, okay, what about the third 2017 study? So, I mean, here also is that, yes, there is a higher intracranial cerebral bleed in the RAF NOAC. However, the anticoagulation in those cases was started at day 3. And it's not necessarily known if it was a direct impact from the anticoagulation, because these bleeds were only picked up at 30 days. It could still be, so basically the reasons why we started between 4 to 14 was because of these studies. And now, looking at that 4 to 14 gap, one needs to consider what then increases your chance of bleeding. So then the consideration of these factors came to play. So you have the factors that are associated with hemorrhagic transformation. There are multiple factors, but we'll be focusing on the size and the type of infarct. So you see that patients with a larger embolic territorial infarct are more likely to bleed as opposed to patients with the small or lacuna type infarct. So this then is a nice illustration as looking what considers it to be a mild, moderate, and severe infarct. So this basically shows that, you know, your minor, yes, you have to consider your NIHSS score, your aspect score on presentation, but this is a nice illustration. So if it's a minor infarct, it's less than 1.5 centimeters. Moderate, it's less than a third of a large vessel territory or deep MCA territory. And then severe would be a complete involvement of the territory, or cortical and deep, or if it's in the posterior circulation, or like the cerebellum here, or the brainstem, if it's more or equals to 1.5 centimeters. So then the recommendations as the years went on now included the type or the size of the infarct in considering when do you start anticoagulation. So this is the ESO Karolinski stroke update recommended considering the infarct size. So then mild stroke and small infarct, it would be reasonable to start anticoagulation by day 4. And then moderate stroke and medium infarcts, consider starting anticoagulation by day 7. And severe stroke, we still are on the side of caution, waiting. However, this was low quality evidence, weak strength of recommendation. And then as the timeline goes, now in 2020, we then looked at the Canadian Cardiovascular Society, which, if anything, as we go down these slides, they basically have the same theme. You have here that if it's a TIA within 24 hours, so looking at the top of the flow chart, patients with AF and acute ischemic stroke, it considers is it a TIA, is it a mild stroke, moderate or severe? And then as you go down, it considers the timing in which you need to start anticoagulation. So with a TIA, it's within 24 hours, essentially going back to what the Europeans said, that TIA 1 day. Mild stroke, same, 3. So you basically have the 1, 3, 6, 12 again. But here they will add other things that as a clinician you need to consider when deciding this. Same, in 2021, you then had the European Heart Rhythm Association, but here they now made it important to consider brain imaging. So it's the same sequence of events. You have the brain imaging. If there's no hemorrhagic transformation, is it a TIA? Is it mild, moderate, and severe? But what's interesting here is that they considered that if in the case of a moderate and severe, it would be beneficial to repeat a CT brain before starting. So exclude hemorrhagic transformation by brain CT or MRI less than 1 day before starting so this was in addition to consider doing repeat imaging. And then lastly, when it comes to these flowcharts, is that because they saw that starting anticoagulations earlier had less adverse effect, they now started to push it even further. So you then had this combined data from prospective registries in Japan. These are not randomized controlled trials, but they basically open the path to working on randomized control trials that try to push starting even earlier. So they then proposed that now instead of considering 1, 3, 6, 12, how about you consider 1, 2, 3, 4? And because of the outcome from observational studies, it birthed this rule. So what is the optimal timing? So, I mean, it also comes, there are ongoing randomized control trials, the Optimus trial, the ELAN trial, but I do have feedback from the ELAN trial, timing trial, as well as thought that early anticoagulation might still have benefits and prevent stroke recurrence, as well as prevent systemic arterial embolization. And then that DOACs offer a significantly lower risk of bleeding compared to other anticoagulates, potentially allowing for earlier initiation and preventing recurrence. So as mentioned, this is basically the ongoing trials. You have the Optimus trial that basically wants to look at starting in the early group less than 4 days, which is basically considered 1, 2, 3, 4, or later 7 to 4 days, as well as the ELAN. This is ELAN trial that was published last year, actually. So this looked at starting anticoagulation early, within 48 hours if you have a mild or moderate stroke, or by day 6 or 7 if you had a major stroke. That was the early treatment group. And then the late treatment group looked at starting it at the 3, 6, 12. Okay. And the primary outcome that they got was combination of, so the primary outcome was looking at whether this person's going to have a recurrent stroke, are they going to have systemic embolization, major extracranial bleeds, or vascular death. So that was the primary outcome, looking at these different groups. And the adverse outcome was more likely to happen in patients who had earlier initiation than later initiation. So this wasn't favorable to starting earlier in the 1, 2, 4. So currently, at least with us, you would still consider the 1, 3, 6, 12, or you'll get expert opinion. Okay, and then this then also to finish, I'm basically adding in, what about patients with hemorrhagic strokes? So reinitiating oral anticoagulants. So say somebody's got atrial fibrillation as the prime example, and then they have a bleed. When do you initiate? So there's no relevant guidelines or randomized controlled trials available as yet. However, the optimal time is basically at least 4 weeks in those patients, according to American Heart Association. Reinitiate at least 4 weeks after the intracranial hemorrhage, or in some nationwide retrospective study in 2022, they looked at maybe between 6 to 8 weeks of this. And this graph basically depicts the reasoning behind this. So looking at the y-axis is the risk, and then the x-axis is the days to restart. So we're focusing on the bleeding risk, so the red line, as well as the clotting risk. So at least waiting 2 weeks, because that's where they cross there by day 16. So delaying anticoagulation resumption after intracranial hemorrhage for at least 2 weeks, usually restarting after around 4 weeks. So as you can see, they don't have a set timing as to when you can start, but when there's a bleed at the initial presentation, you'd wait longer. So we are, so the proposed answer as to when is the optimal time, there are many guidelines with similar themes. The American Heart Association don't recommend early or urgent anticoagulation in acute ischemic stroke. You need to consider the size of the infarct and the severity of the stroke. And then we need results from randomized control trials, and we need our experts in our departments to help us. Thank you.